Okay, now we're going to talk about COPD, chronic obstructive pulmonary disease, which also includes chronic bronchitis and emphysema. So, usually, patients that have had COPD long enough also have chronic bronchitis and they have emphysema, or if they have emphysema, they have chronic bronchitis. So, these three kind of fall in the same category because they pretty much over long period of time end up overlapping and all being basically one big issue. So, and also you throw into that, COPD patients may also have asthma. And it's hard to differentiate between asthma and COPD if the patient has a history of smoking or if they continue to smoke. Imagine any of these with smoking. Well, you're just compounding all the problems. So, a major factor for chronic bronchitis, COPD, and emphysema, smoking, and also repeated lung infections. If you have problems in your lungs and smoking is causing a lot of it, and you can't cough effectively, you can't get rid of your sputum, all the things that a normal lung should be able to do, then you would be prone to a lot more lung infections. Genetics is a big thing. There is a genetic component out there. It's a deficiency of alpha 1 antitrypsin that if you have this in your genetic history, there are young people in their 20s that get full-blown COPD, and it's a horrible disease because they now have lungs of a smoker that's been smoking for 30 years. So usually COPD, emphysema, usually symptoms start around 50 years of age after 20 pack years of cigarette smoking. So 20 pack years is a lot of cigarettes, pack a day for 20 years. So COPD, when it comes on, it's usually obviously an oxygen issue. They have dyspnea, which progresses with exertion. So as time goes on, more and more activities become harder and harder to do. Uh, so maybe somebody that first starts having COPD, they notice every day they walk around the block, and all of a sudden they can't walk around the block as far. Maybe it's half a block, and then it's not even half a block, and then they had no problem walking up a flight of stairs, but now they can't do a flight of stairs, or they can't walk out to get the mail. I mean, who knows? Different things. So it gets worse and worse. Late stages, you have dyspnea at rest. These patients, because of the difficulty breathing, they have weight loss and anorexia because at some point they basically anything makes them difficult breathing. They have they're on low oxygen and they develop this barrel chest because they're having a hard time exchanging oxygen in and out. So it takes so much energy just to eat that's why they lose weight and they become anorexic. Another pattern for these patients, they get this big barrel chest and they have tiny skinny legs because all their energies taken just to trying to keep oxygen in and out of the lungs. You also see their prolonged expiratory phase. So they're doing pursed lipped breathing. That helps them get the oxygen out, the air. So on top of this, these are the patients that really don't have any problems except that. But then if you compound the problem, then they are going to be prone to having bacterial or viral infections, which means more dyspnea. Now you have larger sputum volume and infections and just exacerbating the problem. So what do these patients do when things get bad enough or they exacerbate or just to maintain? Well, they're a lot like an asthma patient. They're going to use bronchodilators, going to use corticosteroids to help the air movement. For some patients, when it gets bad enough for sleeping or even during the day, they may be on continuous positive airway pressure, CPAP. That helps keep the lungs and the alveoli open So it helps transfer and ventilation of air and oxygen. So for years, they basically have thought, it's thought of, that um, high flow rates of oxygen with COPD patients will depress their respiratory center and they will diminish and cease. You know, there's a lot of literature out there that says it will or will not happen. The problem is COPD patients, emphysema patients, chronic bronchitis patients, you know, it's okay if their SATs are at 89. 89 to 90, 88 to 90, that's all right. I mean, they can live with that. Um, so you never really should turn that oxygen up really high on them because they're just not going to get that high. Um, so the best thing for them is you basically should be assessing ABGs if they're in the hospital and they're having an exacerbation. What's the ABG showing rather than the saturation? Um, so the problem that arises with that, or what really ends up happening, is it's thought that a normal person, we take extra breaths, we breathe faster because our O2 goes up. I'm sorry, because our CO2 goes up. So we develop hypercapnia and that causes us to breathe. These patients, though, their drive changes, and when their oxygen gets low, then it causes them to take deep breaths. So if you turn the oxygen up, the thought has always been you will give them too much oxygen and they will not have a drive to take more breaths because their oxygen is not low. So um, I've looked online to try to find, does it really happen? And it's so, you know, I can't, it's just not definitive out there. So just remember that COPD, emphysema patients, they don't need high oxygen. So 1 or 2 liters is going to be fine. Keeping their SATs 88 to 90 is going to do the job for these patients. So we call COPD patients the blue bloaters because they generally have higher CO2 levels. So they're blue, they've got the big lungs, and they also usually have the right-sided heart failure. So these are the blue bloater patients. So collaborative care, well, you do the best you can with what the patient has with their lungs. So you don't want the disease to progress any worse. Hopefully they will quit smoking. You want them to exercise with tolerance to help build up strength. You don't want them to have infections. So they should be participants in their care. They should be compliant with bronchodilators and other medications. You want to improve their quality of life as best you can. And every patient's going to be different with that, obviously. Some patients out there have a fear of using oxygen at home because they think oxygen will become addictive. Well, in a way it is. If you need oxygen, it is addictive. You don't want to be air hungry, oxygen hungry. So the other thing is, if they haven't figured out, they need to learn how to do pursed lip breathing. They need to do effective coughing, the huff coughing mechanism to help get rid of secretions. They need to take their oral meds, bronchodilators, corticosteroids on exacerbation, and probably use their CPAP when they need it. CPAP is used not only for patients that have sleep apnea, but also the COPD, emphysema, chronic bronchitis patients. Let's talk about emphysema a minute. So emphysema is basically when you have reduced air exchange in your lungs. So your surface areas, all your alveoli, are not working like they should. So you're trapping air. These patients have increased chest size as well, that barrel chest. So you don't have near the capillaries to do the exchange of CO2 and oxygen. Cigarette smoking causes this. It destroys and breaks down your working alveoli. Also, environmental and occupational exposures could be a factor. for someone having emphysema. We call these patients the pink puffers. Emphysema are pink puffers. So they have wheezes. They should also be doing pursed lip breathing as well. They have the barrel chest. Um, so these patients have pink puffers because they've got the oxygen, they're retaining oxygen. The other patients, COPD patients, are the blue bloaters because they have high CO2s. So treatment, like COPD, you want to have your lowest FiO2, and you want to prevent CO2 retention. You don't want them to have fluid overload. That'll cause problems as well. They should have on an ABG your PaO2 between 55 and 60. That's pretty low for most patients, but that's what they live with. Pursed lip breathing and also the diaphragmatic breathing. They need to breathe with their diaphragm, not their chest. These patients are going to be using tripod position breathing. That helps out. So the barrel chest for emphysema as well is indicative of using their accessory muscles to breathe. The more accessory muscles you use, then the patient's working harder, but the amount of oxygen they're taking in is adequate to oxygenate the tissues. So that's why these patients are called the pink puffers, is they have oxygen level. They're using lots of accessory muscles below the chest,